Welcome to Medical Logistics 101, Gastroenteritis Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definition: gastroenteritis is inflammation of the stomach and intestines, causing acute nausea, vomiting, diarrhea, and abdominal discomfort. It's most commonly viral, but can be bacterial, parasitic, or toxin mediated. Signs and symptoms: nausea and vomiting, diarrhea, watery usually, but sometimes mucus, cramping abdominal pain, low-grade fever, malaise, fatigue, anorexia, dehydration symptoms including dry mouth, and decreased urine output. Physical exam findings: mild diffuse abdominal tenderness, usually not localized pain like you see with appendicitis. Hyperactive bowel sounds. Signs of dehydration may be present, including dry mucous membranes, tachycardia, and delayed cap refill. Usually no peritoneal signs like you see with appendicitis. Fever may be present, but it's typically low-grade fever. Differential and mimics: appendicitis, cholecystitis or biliary disease, pancreatitis, C. difficile colitis, irritable bowel disease flare, Crohn's disease flare, food poisoning, including toxin-mediated food poisoning. UTI, especially in kids, can sometimes present like this. Differential and mimics continued. Diabetic ketoacidosis, type 1 diabetes, maybe, often I would say oftentimes patients will give you a history of type 1 diabetes, but it can sometimes be younger patients or it's their first episode of this. There's no prior history of type 1 diabetes. Mesenteric ischemia, older adults, and obstruction, where you really need to take a history, you want to know when their last bowel movement was. Diagnostic studies: if symptoms are mild and there's no red flags, then usually it's more of a clinical diagnosis. If there are red flags present or the diagnosis is unclear, I will usually get a CBC and a CMP. Sometimes stool studies if there's a history of bloody diarrhea, fever greater than 101.5, severe abdominal pain, immunocompromised history, symptoms greater than 7 days. C. difficile testing if there's recent antibiotic use or hospitalization history. Pregnancy testing, of course. Imaging if red flags or suspicion for surgical pathology like appendicitis. Red flags: severe abdominal pain or peritoneal signs on exam, high fever, bloody stools. You sometimes see that with Shigella infection, persistent vomiting, and unable to tolerate PO fluids. Signs of severe dehydration: immunocompromised patient or elderly patients with severe pain, definitely a high risk category. Recent antibiotic use, C. diff concern is definitely going to need to be in the back of your mind for sure. Pitfalls: assuming all vomiting, diarrhea is viral and missing appendicitis, especially in early appendicitis. Missing C. diff in patients with recent antibiotic use. Sometimes patients have had antibiotics for either sinus infections, ear infections, whole host of things, and they may not recall that or may not come to mind initially when you ask them about it. Not recognizing DKA patients quickly. If there's ever a question for diabetic ketoacidosis, I will get, in addition to my regular labs, I'm going to get a quick finger stick glucose right when I see the patient, and if it comes back too high to read or off the scale, there's your clue right there. Not checking pregnancy status, including patients who've had a tubal ligation. If they still have a uterus and still childbearing age, need to check a pregnancy status. Underestimating dehydration in children and elderly patients. Two high-risk groups, you have to be on guard against them in particular. Missing mesenteric ischemia in older patients, not a common problem, but it's one of those that you really got to catch it early for sure. Disposition: usually home if the symptoms are mild and they're tolerating PO fluids and there's no red flags on exam. Or oral rehydration, always emphasized, of course. I'll oftentimes prescribe Zofran, oral dissolvable tablets for the nausea, but I'm cautious with pain medication in this group of patients just because of my return precautions. It's going to be worsening pain, bloody stools, persistent vomiting, signs of dehydration. Any of those things are present, they need to return quickly for reevaluation. Usually going to be ED or higher level of care if there's severe dehydration, intractable vomiting, any kind of red flags on exam or history, concern for a surgical abdomen on exam, whether there's findings suggesting maybe appendicitis uh, with that, or cholecystitis, or even diverticulitis if there's a concern that you could have a perforation going on. Elderly or immunocompromised with significant symptoms, two higher risk groups, of course, they typically require a greater level of workup. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.